Hi, I'm Bob Harrington from Stanford University. I'm here in Orlando, Florida at the American College of Cardiology meetings. And it's always a great time to catch up with colleagues about various topics that may be of interest to the general cardiologist, viewer, or listener. And today I have the privilege of having a friend and colleague, Joynt Maddox from Washington University, who is going to talk to us about some of the current thinking on health policy around incentives. And so in an era of value-driven care, the whole concept of how do we incentivize health systems, how do we incentivize practitioners to do the right thing, to do the right thing from a patient perspective, to do the right thing from a society perspective. What are some of the incentive models that work from a policy perspective? What are some of the implications on an adverse, unintended consequence side that incentives might lead to? So again, my guest is Joynt Maddox, Assistant Professor of Medicine at Washington University. Karen, thanks for joining us.
Thanks for having me.
Now, I'll also point out that you also have an appointment in the Department of Social Work, which I guess at WashU is where policy lives.
Where health policy lives in public health.
So you've got a nice intersection of clinical medicine and policy. And for the audience, why don't you let people know, you spent some time in Washington actually working in CMS on this topic. So why don't you just reference what you did there so that people can put your remarks in some context?
Sure, glad to. So I had the opportunity to spend 2 years working in main office HHS in the Office of Health Policy, which is sort of an advisory think tank research group within the Office of the Secretary, who can then advise the Secretary on all matters health policy, so financing and incentives and access and all of those things. I had the opportunity to work on leading a report to Congress focused on value-based payment and social risk factors. So lots of folks around the country, including Congress people, had recognized that as we move toward value-based payment, the issue of social risk is going to be a big one. And no one really knew what to do about it. No one really still knows what to do about it, to be fair. But our job was to put a report together focusing on that issue. So I spent most of my 2 years working on that report.
So let's now start to peel some of that back. From a health policy perspective, talk about just conceptually the idea of incentives. What are incentives intended to do from a policy perspective?
Sure. So really, payment reform in general is the attempt to take financial incentives to signal people where to put their effort and their energies, basically. So
follow the money.
Follow the money.
Yeah.
People will do what they're paid to do. Yep. And you can argue that perhaps in medicine we're somehow immune to that, but in reality we're not.
Yeah, that's been well studied and documented.
Right.
I mean, that was the whole issue of volume-based care, is
right.
that we definitely followed that tranche of money, if you will.
Quite effectively,
yep.
actually.
Yep.
So the intent of financial incentives sort of turn toward quality is to get us to start focusing on quality. It's to really say, we're not just going to continue to pay you to do more, we're going to start paying you to do better. Now, ultimately, I think that moves us in a direction toward focusing on outcomes, toward focusing on what's the outcome of what we're doing as opposed to just the elements of care that we provide. Those two things are obviously a long way from each other, but the intent of financial incentives is really to start moving us more toward thinking about producing the best possible outcomes for our patients.
And from a cardiology community perspective, although we may not understand everything about MACRA and MIPS and alternative payment models, but in the quality arena as a community, we're pretty far along that path. I mean, we understand the issues of performance measures. We understand how it's a process measure, not necessarily the outcome. And we also are starting to understand, okay, we've done a good job on the performance measures. Now we really need to focus on the outcome.
Yeah, in many ways, cardiology is absolutely poised to sort of lead this forward. And just to take one step back, I think another thing that I learned from my time in government is that with the best intentions, people who are not clinicians can make policies that may have a lot of consequences they don't anticipate. And that can be unintended, either good or bad consequences, although obviously we worry much more about the latter. As clinicians, we understand that the point of these things has got to be to drive better care for our patients. We know we can do better. We know that we don't meet the best rates we could of anticoagulation for atrial fibrillation or for stroke care when people show up to the hospital. And our system is not very patient-centered. As soon as you've been on the other side or have a family member on the other side, you know that we can do better. So as clinicians, as cardiologists, particularly in the space where we have a lot of evidence, we really should be able to drive this forward in a way to make sure that all of our patients have access to high-quality care.
Well, let's kind of unravel some of what you've talked about, because I think you said something really important, that sometimes non-clinical policymakers can go awry, not by malintent, but maybe they don't understand the clinical context, the consequences of certain decisions. And as a cardiology community, we've depended heavily on evidence, and you've said that. What is the state of using evidence to make policy?
It's in its infancy, I would say. If you think about how we normally think about introducing a new drug or device, we have a very prescribed set of ways that we test that element.
Yep.
In small
Which
populations,
includes randomization.
Exactly. And even before randomization, you want to get some basic efficacy and safety information. We have animal models.
Right.
And that's a very stepwise, prescribed way that we move things into a broad population. You would never put a new drug out into the population without understanding both its good and bad consequences. We don't do that in policy. Now, CMMI was created in part to create the potential to do that, to have some sort of demonstration projects.
Remind people what that was.
So CMMI is the Center for Medicare and Medicaid Innovation, the Innovation Center.
Yeah, it's supposed to be the hub of innovation for payment models, if you will.
Right. And they have put out a number of experimental payment models on an experimental basis, so in sort of a limited test setting, with the idea that then you could learn, evolve, iterate, and put out a better program if you want to go big. Most of the programs we're currently paid under have not gone through that process.
Which is interesting. The example that I often give now that I oversee a Department of Medicine is residency work hours. Mm-hmm. The concept is the right one, but why didn't we years ago, before changing policy, actually study it in a formal way? We actually made so many leaps of information, whether it was from the airline industry or other industries, rather than saying, okay, how are you going to deal with things like handoffs and unfamiliarity with patients? So you do have to be careful in the policy realm.
You do. And I think what we're seeing now is a little bit of the collision of the best intentions with the reality of the health system also. We don't have the infrastructure we need to be able to do the things that are required to make good policy. So if we could perfectly judge quality, if we could use outcome measures and feel like they're reflective largely of quality as opposed to of underlying patient risk, there's a lot of things we could do. We lack the data infrastructure to be able to do this on the outpatient setting in many cases. So I think as a community we can probably see we need to get better, and we understand that we should be moving in that direction. The methods to get there on the policy side are very blunt instruments right now.
So let's talk about some of those instruments, and I want to kind of do maybe a series of things. I want you to just talk quickly about what is MACRA, MIPS, and alternative payment models, just so it's definitional. Then secondly, let's take an example. You and I were talking off camera, 30-day readmission for heart failure as a important policy initiative. Boy, that one's heating up the cardiology community right now. And then we'll go from there.
Okay, so to start with MACRA. So MACRA was the law that replaced the SGR. I think cardiologists were looking at something like a 30% pay cut if that ever went through.
Cardiologists understand sustainable growth rate. They get that one.
So MACRA was probably a good thing. What it created was two separate payment tracks, and this is all for outpatient payment. Inpatient payment is separate. So the default track is MIPS. MIPS is the merit-based incentive payment system. It's basically just pay for performance.
Yep.
You turn in some basic quality measures, and you get your pay for any given Part B billable service, a visit or what have you, adjusted up or down by a certain percent. The things that you have to do to succeed in MIPS, it looks a little bit like hospital value-based purchasing. It's sort of a Frankenstein of technology, practice improvement initiatives, cost, and quality. Those things all get lumped together. You get a score, you get a bonus or a penalty. The second track,
Let's talk about the size of those penalties, because they started off very modest, and now they're not going to be so modest.
They're not going to be so modest. So the precursor to MIPS, which is what we're under now, the value-based payment modifier, was 1%, essentially. Starting this fall, so fiscal year 2019, which for whatever reason starts in October 2018, is a 4% up or down penalty. It's 5 the year after that. It eventually goes up to 9.
Right.
That's
and
real
remind
dollars.
people that the 4%, it's too late to affect it.
Yes.
Those data are in, so to speak.
2019 penalties and bonuses are based on 2017 performance.
Right.
So we are currently in the 2018 performance period, which will affect payment in 2020.
Right. So as you said, we're going to ultimately get, unless the law changed, up to the 9% mark. And as they say, that's real money.
It is real money. especially for practices,
Correct.
which generally can bear a lot less risk than hospitals and health systems.
Let's talk about the APMs, which I thought when they were initially introduced might be more interesting than MIPS.
Yeah, and I think they will be eventually.
But yeah, they're clearly not there.
So that's the track that CMS wants people to go down. If you're looking at a fork in the road, there's the well-traveled, fairly straightforward pay for performance. There's this murky, what can we do, alternative payment model track. That's where they want people to go. The carrot is a 5% flat bonus if you go there. The problem is there's not much to go to at this point.
And they're seeing people kind of go there because the 5% is not going to take a lot. The challenge is that once you're down there,
then what do you do?
Then what are you going to do? Yeah.
So I'd say, if I were guessing, I would think that the most common way that cardiologists are getting into that track is through ACOs, accountable care organizations. If your organization is one of those, you are down that track.
Right.
You can stop worrying about it.
Yeah.
But for a practice or a hospital that's not currently part of an ACO, we don't have much there. The Bundle Payments for Care Improvement Initiative Advanced, which actually closes enrollment, I think, in 2 or 3 days for the first year, is really the first sort of feasible specialty track to go down there for cardiologists.
Yeah, and there's a bunch of bundles for cardiologists.
There are a bunch of bundles for cardiology.
That we do all the time.
Exactly. It's things like PCI, ICDs, and even a couple outpatient bundles, actually. It's a little early to know what's going to happen there. I think CMMI has actually been quite thoughtful about taking what they've learned from the initial BPCI and making a few improvements to BPCI Advanced. So they have not released full details, but hopefully it will be a feasible opportunity for some.
Well, the great thing about cardiology is that we are an evidence-driven field. We're also a data-driven field, and more than other areas of medicine, we do have data infrastructures.
Yes.
We have Get With the Guidelines, we have NCDR, we have now the Pinnacle Registry through ACC. There's a lot of ways that people can participate in both contributing their data, but then also having their data benchmarked.
Absolutely. And, you know, MIPS is a tough program. MIPS was the government's effort to take urologists and cardiologists and endocrinologists and throw them all into one bucket and try to make something that was one size fits all. I'm not sure that makes a ton of clinical sense, but you could imagine that if we as cardiologists got together and said, what are some high impact measures we care about? Can we collectively move this ball down the field? That this would have been perhaps a different way to go about it. So I think thinking about the underlying goals of that stuff and thinking how we can use MIPS to help us move quality forward is probably better than trying to take on that Frankenstein umbrella program.
Well, I think that's well stated. Let's take on one of the incentives, which has garnered a lot of interest in the community, including at these meetings.
Yep.
And that's the 30-day heart failure readmission. The controversy goes something like this, that sounds like a good idea. A lot of people who have heart failure are getting readmitted. If we put programs in place that can reduce that risk of readmission, which from a patient perspective is a bad thing, we therefore ought to improve heart failure care. And at least some have argued that, well, what's happening is that we're putting people in a perilous situation of not readmitting them, and actually the risk of mortality is either is getting worse.
Yep.
I'll leave it at that. And a pretty big debate in the community.
Pretty big debate in the community.
You want to give your take on this?
Yeah, I will go squarely down the middle, which is
which is a good policymaker.
Sporting, right? Yeah, exactly. I learned from my time in
There
government.
you go.
I think both sides have merit. I think if we went all the way to either side, we would miss good things for our patients. So the argument that reducing readmissions is a good thing, I think, has merit. We've all seen patients come back to the hospital because of failures of some sort.
Yeah.
Now, whether or not it's a hospital failure versus a system failure has been the source of some discussion.
Versus a community failure.
Or an individual failure.
Right.
I mean, some patients have chaotic, unlivable outpatient lives.
If you don't pick up your meds and don't take them, you may get readmitted.
Exactly. If you don't have access to care, you may get readmitted. If you are prescribed the wrong medications, you may get readmitted. So addressing readmissions is a good thing because it actually requires us to get out of our comfort zone and say, how are we going to be patient-centered about this? When do they need to see someone in follow-up? How can we make sure they get their medications? That's different than a hospital quality measure of give someone an aspirin.
Correct.
But it's fundamentally where we need to go next. So conceptually, I think the concept of heart failure readmissions is a really important one. And it's pushed a lot of innovation in the outpatient setting for infusion centers and home visits and stuff that's really good and patient-centered.
Yeah, and has also made people realize you have to open up your practices to have acute care visits.
Exactly.
So I agree with you. It's done a lot of good things.
Full stop. There are good
Let's talk
things
about
that
the other
come out of
side.
that. The flip side is, why do we see these patterns of heart failure mortality going up at the same time as readmissions are going down? I think it's an open question. I think there are a couple different potential answers, and I hope that someone out there is working on trying to figure out which is true. They may all be true. One thought is that working on readmissions has essentially distracted us from working on mortality. That we're so worried about people coming back into the hospital that we have failed to really keep pushing on that inpatient mortality. That's a hard thing to prove. There's probably some merit there. Every sought opportunity is a lost opportunity in some ways. I think another thing that's probably happening is the population of heart failure patients in the inpatient setting is really changing. It's a lot of HFpEF, for one thing, which we don't really even have
good
so much to do for.
Yeah.
And those folks are also more likely to die of other things. So it's becoming an older, sicker population.
With a lot more comorbidities.
A lot more comorbidities. And so some of the trends, I think, probably reflect actually differences in admission in some ways as we've cut people out of the hospital.
Yeah, and as you've said, that it used to be that a lot of the heart failure was, acute MI with a large infarct, and now with acute coronary syndrome care, that population is getting more limited.
And more people survive STEMIs and go on to have a longer course of very complex multimorbidity sort of scenarios. So I think there is some merit to that argument too, because on a population basis, we're not doing that much worse with heart failure. It's a hospitalized problem, really.
As a policymaker, then, would you say that the answer is not to discard the measure? The answer is to try to figure out why we are seeing these patterns of mortality and try to figure out mechanistically, perhaps, what contributes to that, and maybe take the best of the readmission learnings.
Yeah, I think one thing we do need to do is to sort of right-size policy, if that makes sense. Right now, mortality is part of the value-based purchasing program. It's a little smidgen.
Yeah.
It's actually probably more harmful to your hospital financially to have a urinary tract infection than a heart failure death. I don't know that exactly statistically, but
go figure.
Infections are all over the place in payment models, including a whole separate infection payment program. Mortality is one little sliver.
Yeah.
That to me doesn't feel right. And having a program that only focuses on readmission without taking into account competing risks. Do you keep more sick people alive who are then more likely to be readmitted? I think there's a lot of ways where we could think a little bit more systematically about what as a community we want to incent. I don't think we should throw out the concept of readmissions. I just think we may need to rethink kind of how we approach that in concert with a global approach to how well we're doing for heart failure. The same is true for acute MI. I don't think we should throw out thinking about little pieces of it that we don't like.
Yeah, I remember in the early days of the time to treatment metric, there was a lot of concern that, the door to balloon time was so stringent that people were just, inflating a balloon in the guide catheter to be able to say they inflated the balloon. And of course, that wasn't what the intent was. And I think we've gotten over that in the AMI world, and things have actually, the needle's moved.
Yeah.
AMI mortality clearly is continuing to
decrease. And AMI
decrease.
mortality is under a readmission program too,
right.
And its mortality continues to drop. So I don't think it's as simple as just saying one program causes something and one doesn't.
Yeah.
It's to say these are different conditions, and we need to collectively think about the sort of package of care we deliver and how that's going to get better.
Well, you said something that maybe we'll end with. It's the we think of sort of basic science and clinical science. In fact, there's a lot of overlap here. That what we're really trying to understand is a biologic phenomenon that has mechanistic underpinnings to it. And if you think about that as a scientist, it starts to help you think, okay, we've made an observation, now we need to unravel it.
Yep. And iterate and test and learn.
Exactly.
And, I think one thing that we can do as clinicians is to try to keep informing this policy discussion. There are not very many clinicians in government, and there's certainly not very many in policymaking positions. And so seeing this as a partnership and a way to have us drive our own fate, I think is ultimately probably going to be more useful than just sort of trying to ignore it. It's not going away, but collectively I think we can make it better.
And I agree with you, as clinicians we need to be engaged, and we can be engaged, as individuals, as you have, but we can also through AHA, ACC,
Yep.
really play important roles there.
Absolutely.
So Karen, thanks for talking with me. I
Thank
could
you.
do this for a while. There's a lot of interesting things to chat about. And I want to thank you, our listeners, for having a discussion with Karen Joynt Maddox from Washington University in St. Louis about some of the implications of health policy incentives. Thank you.